say, for high doses of minoquinone 4, for instance, heard in some videos that maybe unsafe when having unstable plaque. Yes, I do talk about that, about stable plaque. I don't recommend initially. I usually recommend people take the lower dose, which is the about 100 to 200 micrograms initially, or just get it from the cheese like Gouda and stuff like that. We want initially to lower the inflammation. We want to basically, for a year, we want to accelerate the increase in calcium into the soft plaque. It's a bit like, when you scratch your hand, and if you keep on scratching it, that means inflaming it, you'll always have some soft plaque or soft, that hasn't healed properly. But if you leave it alone, it eventually will calcify. It'll actually get a lot of collagen in it, and it will basically then become stable. At that point, then you can use much higher doses when you're in a low inflammatory state in order for the reversal. So remember, most of the experiments that were done on rats in Japan, and they basically induced endothelial dysfunction, which was new endothelial dysfunction. Then came very high doses to reverse it very rapidly. That sort of works. Now, they did do some research with minoquinone 4, only minoquinone 4, not minoquinone 7, in Japan and the Netherlands, in terms of higher doses like the 5 milligrams. And they also did with very high dose of 45 milligrams. But these were people that were basically also taking statins, and statins tend to basically stabilize plaque. They do have a lot of side effects. The mitochondrial poison have a lot of side effects in that regard in terms of coenzyme Q10 and many other things. You could supplement. Japanese do supplement ubiquinol specifically for that, but they do have a stabilizing effect on the to stabilize and increase calcification. It's one way that actually they stabilize plaque and reduce secondary incidents. It's not because lowering cholesterol, and it's not because as an anti-inflammatory that, the piss poor. It's really the stabilization of plaque by increasing calcification is the way. So if somebody's just come out of an operating theatre and they're not willing to change their diet or everything, actually being on a statin with a coenzyme Q10 for a year, because after that it's useless, to stabilize that plaque may be of some value, some utility. Now, long term, it's going to cause deficiency. Long term, also if you look at the LA veteran study, it did show an increase in cancer. So it is a mitochondrial poison. It's not a good thing, but at the same time, short-term use may have some value in plaque stabilization in that regard. That's why I did that video of mine about recently. It was probably quite a few months ago now, about the CAC score, not to worry too much. It's, more about this sort of stable and unstable plaque. Now, if you've got stable plaque, then going high doses is fine. So once you've got, you go in, you check, you've got really good stabilized calcification in your arteries, then you can go high doses in a low inflammatory state to clear it all out, which is what I did. So that's the way of doing it. Make sure it's stable before you start clearing it out in that regard. Actually, even if you use high doses, from what the research has shown that they did I think the one specifically in Japan, it actually showed that even if you used high doses, it didn't seem to have a very good effect. It seemed like the body was counteracting the minoquinone 4 and basically just continued to calcify and stabilize the plaque because it was a healing process. So giving it more minoquinone, the body's going to say, well, I'm doing something else. I'm trying to stabilize, and then I'll use at a later stage. At a later stage, once it's stabilized, the healing of the endothelium happens, then it can come in, pull away all the actual, because most of it will be, you know, calcium that'll actually be pulled out, and also it'll clear out the actual the fibrosis also will be broken down as that calcification happens, as the healing behind happens. And then over time, that endothelium, as long as it's not inflamed and stuff like that, will slowly regrow glycocalyx to repel with a negative charge, and improve the endothelial function in that regard, as long as you're not throwing in sugar and collapsing the glycocalyx every couple of hours like modern people do. And then you'll basically have less stickiness, because the little the glycosylation of the tips of the glycocalyx, they will then acquire a negative charge, and that negative charge will increase nitric, through the nitric oxide process, or grounding that we can do. And then the pericellular matrix of lipoproteins and red blood cells and whatever else that have got lower glycation, and their pericellular has got a negative charge, means that they don't become sticky. You reduce the clotting factors and all that, and things flow much better within the arteries, and they vasodilate much better, which basically means better blood pressure control and all these sort of things. So it takes time. It takes time and patience and all that. But yes, they talk about it in general, but at the same time, the body seems to, even if you're putting higher doses, from what this Japanese research showed, it seems to sort of counteract. I tend to basically go, let's put in some low dose, like 200 micrograms of menaquinone 4, and let's use that to take out of the soft tissue the calcium, like out of you may have in the skin, you may have in different tissues in the lungs and other areas. Pull out that calcium, and then when the body's actually healed that part, it will basically then be a good idea to go much higher. But I always say, take a year, stabilize the stuff. Yes, your CAC score will go up, but it will, and that's, I think I called it CAC something. If you're Harris upon CAC, you'll find the video that I talk about in regards to more details about this sort of stuff. So I'll leave it at that.